And I'm going to go ahead and introduce our first speaker. So we have Dr. Judith Feinberg from the WVU School of Medicine. She's a professor of behavioral medicine and psychiatry, as well as a professor of medicine and infectious disease. And with her is John Dower from the Director of Operations at Ascension Recovery Services. So I will turn it over to them at this point to share the program, the West Virginia Peers Initiative at WVU Medicine in Morgantown. Hey, Judith, we can't hear you.
Can't hear me at all?
I heard that, hear you at all. I heard that part.
Okay. Maybe I'll just talk closer to the screen because I'm not muted. All right, well, John and I are happy to talk about the WVHA initiative. That acronym stands for Enhancing Education Recovery and Survival. This really was the brainchild of one of our colleagues.
I'm sorry, Dr. Feinberg, I don't mean to interrupt you. Somebody is typing on their computer, and either mute your phone or please stop typing. Thank you. Sorry, Dr. Feinberg.
And Jim, this is Lily. We can't hear Dr. Feinberg at all.
Okay.
I need to try the call-in number in addition to everything else. It says I'm connected and I'm on my computer.
Yeah, I think the audio just on your computer, Dr. Feinberg, is a little limited. It might be helpful if you would just use the dial-in number.
Okay, if you give that to me, I will do it right away.
Okay. I think maybe what we'll do for time purposes, while Dr. Feinberg does that, we have a really aggressive agenda for the next 60 minutes. So Lillian, if I don't mean to put you on the spot, but can we go ahead and switch to Charleston Area Medical Center? And then we'll come back to Dr. Feinberg when she dials back in and you're complete. Is that all right with everyone?
Yes.
Sure. Okay.
Okay.
Hey, Jim, can you hear me okay?
Yes, can hear you perfectly.
Anyway, let me take it off speaker, maybe that'll be better. Thanks for letting us have the opportunity to share where we are, and we're kind of on the front end of getting started with our Recovery Coach program. We're working with Recovery Point to secure people for a Recovery Coach program through a grant that we partnered with them on. We're looking at two pieces. One, putting a recovery coach in the drug-free mother-baby program that's coordinated with Kelly Gilbert. We've had a coach in place in that project since June. It's been a really good structure to put our first coach in because the drug-free mother-baby program was already established, had a solid staff, had a lot of structure to it for meetings and information. So putting that person there has been very helpful. What we did with that coach was to put them in the high-risk OB clinic 4 days a week. They assist with enrolling drug-free, some of these moms in the drug-free mother-baby program. The coach meets individually with our admitted inpatients, even if they haven't been seen ahead of time. So that's been very helpful. We have them participating in the group clinic sessions with the moms. The coach is going through the certification process for recovery coaches. It's a 46-hour program of classroom time that they didn't have before they came to us. So this coach is already well underway in that process. They participate in the conference calls for the entire drug-free mother-baby program that networks around the state. So they've really become part of the team in the Drug-Free Mother-Baby Project. They work closely with our physician and our addiction coordinator in activities within the program as well as in the community. They've been able to attend education sessions with our staff for other projects like the Perinatal Summit in Charleston. And so being able to engage them with the whole team has been a real positive for us. So we really think that the coach that we have in our Drug-Free Mother-Baby program is going extremely well. She's well received by the patients, well received by the staff. So that's a real strong project that we've gotten started. So we're real pleased with that. As we talk to our folks about what, since that was our first coach coming in, were there things that we'd like to see different than where we started, what we learned that could be better? We'd like for them to have had more of an orientation to what being a coach in a healthcare facility role was going to be like. Just that kind of basic training of as a recovery coach, how do I approach people in that clinic and those activities. We'd like for them to have, we wanted them to have identifying uniform type clothes. They're wearing slacks and polos, and so they have that now. We'd been told they would have a computer, cell phone with them. We didn't get that at the very first. All that's been fixed. We found it's really helpful for them to have somebody at Recovery Point to keep in touch with, but also a contact person within our the team that they're working with, who's their go-to person if they have issues or if our coach needs support, because we want to make sure we're providing that for them as well. We've had good communication between Recovery Point and the manager of the unit, which has been a real positive for us. So we felt the Drug-Free Mother-Baby program was really a good start for us in working with recovery coaches. It's been real positive. We also have funding for 3 coaches to be placed in the emergency department. So our emergency department managers met to talk about how to best use those folks because we have 4 facilities. Did we want to split them up, or how do we want to use them? The group decided that they would prefer to put all 3 people at one hospital to get the maximum coverage of time in that hospital to be able to better assess the performance and the project improvement we were making in that area. So while we've had funding for 3 coaches, we have yet to get our first coach in the emergency department, and we're putting them all at General Hospital. We had the first round of interviews where we had offered a position. That coach subsequently decided to not take that position for personal reasons. So we did a second round of interviews, and we had offered positions to 2 applicants. One of those folks took a full-time position at the hospital in a different role, and the other person had to be cleared through the West Virginia CARES program. So that's been going on for quite a while, and just this morning we were notified that that person has now been cleared by West Virginia CARES, and we'll be able to get them started. So this week, Recovery Point's making sure their health reviews, their vaccinations, all those things are up to date. They're taking a CPR class before they come, and then they'll work with our managers to define their start date and get going with that. To prepare for that in the emergency department, our managers have met with the medical directors, with our social workers, and with the staff to talk about the role of the recovery coach, how they're going to function in the emergency departments, and how we'll onboard them here at CAMC. So we're looking forward to that, getting one started. Then later this week, Recovery Point tells us that they plan to repost those jobs. And I understand St. Mary's also needs one coach, so we'd be working together to have another posting and get that out there. So we would hope that with this next round that we'd be able to come up with our last two folks and get them on board. So that's where we are as of today.
Thanks so much, Lillian. Does anybody have any questions at this point? Or any discussion? Our speakers are going to stay on till the end, so and we'll hopefully have a few minutes for any questions or discussions at the end as well. So we'll go ahead and move back over to Dr. Feinberg and John Dower. So Dr. Feinberg, can we hear you?
Okay, I'm connected by phone. Can you hear me, and is this okay?
We can hear you. There's an echo.
You know, let me just turn this over to John, since I'm having all of these technical problems.
Sure. So I can kind of take a... So West Virginia Peers is an initiative that initially started with funding through the University of Baltimore and the Office of National Drug Control Policy. And the goal of West Virginia Peers was to build a sustainable model to impact the mortality and morbidity of individuals in Monongalia County. So we initially started with approximately 2.5 full-time employees working on that particular endeavor, connecting with community partners with a range of services offered, everything from harm reduction all the way up to abstinence-based and a lot of social services for needs like food, housing, clothing, every barrier that it takes to get an individual in recovery. Through the course of creating relationships with community partners, we were able to obtain some grant funding through the state's STR grant to exponentially increase the amount of peer recovery coaches. So currently we have 7 recovery coaches that are all full-time employees. We have memorandums of understanding with different community partners ranging from drug addiction drop-in centers to harm reduction programs to mental health, PHP and IOP level of care, to the behavioral health facility in Monongalia County, which is Valley Health Systems. We've overcome some HIPAA concerns by implementing business associate agreements that allow us to be a continuation of that care and overcome the hurdle of HIPAA and privileged health information transferring back and forth between the parties. To go over a little bit of quantitative data, we have since January 1, which, to give you an understanding, we went from 1 recovery coach on January 1 to around 3 in March to 7 starting in June. We have had approximately 869 engagements with individuals in our community, about 450 of which resulted in referrals to services. Part of what we're doing is also collecting data on a secured red cap that's kept on WVU's server behind some firewalls. And we're also doing research to show that an intervention using a peer recovery coach does result in effective services. So our goal of that particular endeavor through the University of Baltimore was to enroll 100 patients. At this time, we have 86. About 60.5% of those individuals have had an overdose in their recent history, with about 42.3% have overdosed in the last 2 calendar years. The most frequent identified place of overdose was in their residence or in their car. So we're being able to identify some real data on where these where these overdoses are occurring or where the best place it is for an individual to, or a peer recovery coach to engage them. We got some talking points specifically about what they wanted us to talk about today, and one of which was, so how do you identify an appropriate recovery coach? In my experience, and I manage 7 of them, and I'm a certified peer recovery coach myself, I look for individuals that are in sustained remission from a substance use disorder, that have lived experience, that are actively engaged in some sort of mutual aid support group, whether that be Smart Recovery, Refuge Recovery, Alcoholics Anonymous, Narcotics Anonymous. I truly believe that the education is vital, and all of my peer recovery coaches are state certified with the West Virginia Certification Board of Addiction and Prevention Professionals. And we also implement, like many other health services, a mentorship program. We provide clinical supervision biweekly with our entire staff to go over what barriers they're facing, to deal with any concerns that they may have, and to provide a continued education piece so that they can be more effective and more efficient in what they're doing to help individuals in our community.
Thanks so much, John. While we're here, does anybody have any questions? I appreciate that perspective from your at Ascension Recovery Services. So that's one we haven't heard yet. So any questions or thoughts for John? Okay, we'll go ahead and we're going to move to Tasha Miller from St. Mary's Medical Center next, instead of going to Cabell next. So Tasha spoke at the kickoff, and she's just going to do provide an update on a little bit about their program, in case there's folks on that weren't at the kickoff, and just an update on St. Mary's. Tasha?
Hi, everyone. We are still trucking along. We have now got a peer mentor in our ED. He's been here for, this week makes 3 weeks, I do believe, and he has already had some successes. So patients who wouldn't talk to me would engage with him. So that, I mean, they've been in the same situation before, and I think that connection is very important. So what happens is the physician or nurse will see this patient and recognize that there is a substance use disorder. They'll ask the peer mentor to see the patient. They go in and engage them at the bedside and hopefully get them into some sort of treatment program if the patient is willing. Funding sources, that has been grant funded for 2 in our ED, just as with some of the other facilities here in the state. And they're employed by Recovery Point and contractual here at the hospital. We are allowed to have 2, but the second one that we had hired was offered a better position at the facility where he was already and chose to stay there. So we will be with CAMC doing some interviews coming up soon. We have not yet expanded from the ED with our peer coaches. However, that is definitely in the discussions here at the hospital. We are just waiting for approval. And with all the data that the peer coaches are collecting, we're hoping to be able to prove the need for them once the grant ends, and hopefully we'll get sustained through funding through the hospital. I'll give you a couple of examples of successes we've had. We have a young lady who we had seen on OB. We don't get a lot of the substance use on OB here, but we did have a young lady who we saw back in December. She had the baby, had not told anyone that she had substance use disorder. Of course, as soon as the baby started to withdraw, and we do urine drug screens on all of them, we knew exactly what was going on. They called me up. We saw the patient, got her into a program, and she was able to work with CPS and keep her baby, which was a big thing for her. And she came and saw us a few weeks ago, and she's doing fantastic. The baby's doing fantastic, and she is still with her mother. So that is definitely a huge success, I think, because a lot of times these patients don't know where to go for help, so it's just one of those things that maybe she would have got to keep her child, maybe she wouldn't have. We are tracking here at the facility the types of treatment that we refer patients to, anybody who refuses to see us, any AMAs, the number of peer mentor consults, plus the number of actual encounters by the peer. We're looking at readmissions, things like that. We are up to, Dr. Basin and myself, as of today, 330 consults with no marketing whatsoever still. But a little bit of data that we have collected from December 1st, 2017 through June 15th of this year, we had seen 160 patients. And of those 160, we actually had gotten about 36% into an MAT program and about 22% engaged into other types of treatment, so outpatient, faith-based, inpatient, Narcotics Anonymous, Alcoholics Anonymous, some sort of treatment. So 50% of those 160 patients basically went to some sort of treatment program, which is a huge number when you consider that they likely wouldn't have went anywhere before. We are still encountering a few barriers. Treatment availability is improving in our area specifically, but getting patients Suboxone from pharmacies is still an issue that we're working on. And Cabell has a pharmacy that has started working with us, so that has made it better. And then inpatient programs around the state that will accept a patient who is already on Suboxone. So I'll give you an example. A patient who has a history of opiate use disorder, currently on Suboxone for treatment of that, but they also have an alcoholic use disorder. Therefore, they want inpatient treatment for this, but we can't get them anywhere because no one would accept a patient who's currently on Suboxone. So if anybody knows of anywhere that will accept a patient like that, please speak up during this call because we could sure use the help. And I hope everyone else is doing fantastic things as well to help this particular patient population.
Thank you, Tasha. Does anybody have any questions or want to speak up about one of those programs at this point? Okay, so I think Tasha can stay on for a little bit, but not all the way until the end of the call. So, but if we get any questions for you towards the end, after you've had to log off, I'll make sure that we get those to you and get the answers out to everybody.
Okay, great. Thank you.
Yep, thank you. Okay, and Maria, can we hear you? We have Maria Summers from Cabell Huntington Hospital to provide an update for their work as well. We heard from Maria at the kickoff as well.
Good afternoon, everyone. Actually, you've heard from Charleston and St. Mary, so you're just going to hear how Cabell's doing pretty much the same thing. And Morgantown, it sounds like, is on their way. But I'll just give you a little update on what's going on here. We started our program actually on August the 6th, and we have two recovery coaches that work in our emergency room that we partner with Recovery Point, who provided that to us through the SAMHSA grant. We are, they cover 7 days a week. Each one of them are doing 10-hour shifts. And one day, one of our busiest days, we identified through our data, which is on Thursday, they provide double coverage. And they both stay busy on that day. Also, we have two peer coaches that's serving our NTU mothers at this time. Healthy Connections and Valley Health both had the peer coaches through the grant assigned to them, and they've been coming in on Tuesdays and Thursdays and being a support system for the mothers that are in our neonatal therapeutic unit. The coaches here complement our social service department. They when they make a consult to the patient, they go back and speak to the case managers and social workers who put the communication and their interventions in the note, in their medical note. We're trying to collect data points at this point for consults, and we just validated that data yesterday to make sure we were capturing all of it. And as of yesterday, they had 71 contacts since August the 6th, and of those 71 confirmed consults. When I say that, that means these are the people who allowed them to stay in the room and speak to them regarding recovery. The 38 of those accepted as some form of treatment into a treatment program. And now what we're missing right now is our outcome data, because we're trying to identify some points and make some opportunities to find how we can follow up if the successes of those referrals. I attached our policy on here. There were some people who had already reached out to me early after we spoke in our first one who wanted to have a policy on hand. You can see it's really basic on here, and it just goes through the steps where our nurses do the 3 screening questions to identify if there is a substance use disorder. That is kind of a preliminary. There have been patients who've captured who answer all those questions incorrectly, but these recovery coaches are so well trained that they, social workers have case manager goes in, maybe interacts with the patient, and they identify that there is truly a substance situation, and they've intervened on those kind of patients as well. If you have any questions about my policy, you can reach out to me, or we can ask questions in the end. We do meet monthly. We just had our, like our 3rd or 4th meeting yesterday, and in that meeting, it's Valley Health, Healthy Connections through Marshall University is represented there. Case management, the peer coaches show up so we can talk about barriers and challenges they're experiencing. They actually were working through processes. We have a MOMS program here that just kicked off in the last 2 weeks for the mothers who are not associated to outpatient care at this point. So they're in this meeting as well, and the peer coaches will also be joining them in some of their group therapies and other services that they'll be providing to some of the mothers. I'd say our biggest challenge at this point is our inpatient peer coach that we don't have yet, and we are actively pursuing. We've already got a proposal ready to get that approved. And our next steps is getting our emergency room physicians. They have been probably they weren't negative, but they stood back cautiously, wondering if this is really going to work, having these peer coaches in their emergency room. The ER staff absolutely have seen a huge difference, because what it does is it allows somebody to go in and relate to these folks who are usually very anxious if they're in withdrawal, and allows them to break those barriers down and let them know somebody else can understand what they're going through. But our physicians, that barrier is also coming down. So our next steps there is looking at some kind of dispensing of naloxone from the emergency room for the overdose patients. There's some models out there that also do start the 3-day dispense option until they can get into treatments, but I don't believe we're there yet. But those are future goals that we have set here. So that's really all I have to share right now.
Thank you so much, and thank you for sharing that policy. If anybody doesn't have it, you can reach out to Maria or let me know, and we'll make sure you get it. I did just want to ask, is there anybody who didn't speak today that is in the process of putting recovery coaches into the emergency room or another unit? We'd love to hear where other folks are. Okay, and I think Jim had a question as well.
Thank you, Hallie. So I was just going to remind everybody not to do what I was doing, which was speaking to you all while I was on mute. So if you were going to comment to Hallie's question and we didn't hear you, you might want to unmute and join the conversation. That's what I had to do. So I had a question for each of the presenters today. I think we're going under at least the assumption that all of you are funding these recovery coaches through current grant funding. I don't want to assume that without hearing it. And then I'm, again, projecting here and looking for some feedback for everybody, going under the assumption that if it is grant funded, that part of what you're doing is looking at evaluating the program and recognizing that if it became an expense that was to be absorbed by the hospital, that there is value, economic value for doing that, that's something you can justify. So I'll kind of stop there and throw that out, no particular order.
So this is John Dower from Ruby Hospital. I'm actually for Ascension Recovery Services. You know, sustainability is a big point when it comes to utilizing PRCs and any intervention, especially in the ED. Fortunately for West Virginia, we had the new waiver that went through, the Medicaid waiver 1115, that is allowing for recovery coaches to be a billable expense through Medicaid. While I do believe that it's extremely important to prove concept that these interventions using peer recovery coaches are essential, it also goes to show that there can be a billing process to cover the funds necessary to keep this sustainable with recovery coaches. Hospitals are going to absorb some of the costs, but the beds that are tied up by individuals that are waiting because they don't have access to care is going to balance out the need for having recovery coaches. That's our belief and what we're seeing through our implementation in Morgantown.
Thank you for sharing that, John. Lillian?
Yes?
How is CAMC funding this program?
Well, we're having a lot of discussion about that, and we don't have that answer yet. You know, I think that it's going to be very important to see and be able to document the results that we're getting. There's certainly a lot of interest and already getting requests to expand the services, so, but we have not yet been able to identify resources for it.
Okay. So we are aware, and you all have probably read, that there is a very, very large SAMHSA grant that West Virginia is waiting to hear about. I was in Washington, D.C. 2 weeks ago with SAMHSA and Region 3, and that grant funding came up. The state seems to believe that we're pretty much a shoo-in to receive that money. It looks like for West Virginia that would be $27 million to the state, and a very large portion of that funding is supposed to be about this peer recovery coach process. And while they have not named how this will work yet, we are under the belief that a fair amount of that money, some portion of it, is going to come to the hospitals to be able to implement this program, and it looks like for a period of 2 years. So for those of you who are listening and questioning whether you could ever get into a program like this from a financial perspective, there may very well be that opportunity soon. We're hoping to hear, I believe, in October whether we've been awarded the grant. And there may be opportunity to do this. And I think for those of you that are thinking you'd like to, but not sure how to get started, the money may make that an opportunity to do a 2-year study and really look at the value of the program all the way around, because we might find that it has a lot of redeeming value and clinical value, but still left with the burden to pay for it. So just wanted to let you all know that's coming. Anybody else have any comments on this topic?
Hi, Jim. This is Maria Summers from Cabell. Can you hear me?
Yes, ma'am.
Okay. The grant that we have here in Huntington is through Recovery Point. That's who the grant went to. So that's
okay.
That's who it supports. It's not the hospitals.
Okay.
I just wanted to make sure everybody had there was clarification on that. It allowed Recovery Point to provide peer coaches.
What's the length of time on that? Do you know, Maria?
It's a 1-year evaluation with a possible extension.
Okay.
And we are doing data in order to show sustainability as well as they are. And as Mr. John said from WVU, the Medicaid DHHR has already approved the waivers. So those are the things that are being worked out in the Recovery Point side, and things that we'll be evaluating as we move forward as well.
So this is Brenda from St. Joe's, and my question is, does Recovery Point have any plans for helping the rest of the state? Because we don't have a close option.
I can't answer that question. We're a partner with them, but there is a gentleman by the name of Matt Boggs, and I know he travels all over the place, so he would definitely be the person to reach out to find out what their means are.
Okay, thank you.
And if I can find his contact information, I will provide it to Jim, and they can share it with everybody.
Great.
Hi, everyone. And I just have a comment from Dr. Feinberg. And so she was just adding that she really believes that hospital support is key in that it will unclog the emergency departments and prevent unnecessary hospitalizations, and that these recovery coaches will strengthen the social network that is essential for communities to recover from the opioid epidemic.
Yeah, good point, Dr. Feinberg. I think that's the reason that that we need to continue to collect data on this. Each of you need to be looking at this internally. Things like endocrinitis and the amount of money it's costing you to take care of these people for extended hospital stays, and opportunities for those numbers to begin to decline. Obviously, it's really unique, so it's hard to broad stroke that across all the hospitals, which is why you really need to be looking at these things internally and identifying these cost opportunities. I'm still, again, as I said, I'm very hopeful that while some of you are working through grant funding from other organizations, because there is a lot of money being thrown around out there, I'm hoping that there will be, in fact, money available for those of you who don't have an opportunity to do that to look at a program like this locally and at least have that funded for a period of time to do the study.
Agree, and Dr. Feinberg did just add that that we can't continue to do this indefinitely on those time-limited grants from the external sources. So something we'll have to give in order to be sustainable.
Mm-hmm.
Jim, do you want to go ahead and spend a couple minutes talking about data.
Yeah, if we don't have any other questions regarding that part, then let's use a few minutes to discuss where we are with data. So right at the moment, we have a mixed group as far as we have some hospitals that have successfully been able to extract data from their systems and have submitted that to us for review. And we have others who have not been able to extract data at this point but are continuing to work at it. And then there's the in-between. We're able to get at some things, for example, administration as an inpatient. That one's pretty easy to get to, whereas prescriptions at outpatient might be more difficult for some. So everybody is in a slightly different place, but at this moment, we are on the we're on the uphill side of data collection. So for those of you who have completed the process entirely, it's going to still be a little bit before any of the first set of reports start to become available. At this stage, I can't give a date for that. We're working with too many hospitals on their data in order to know when we'll be at a critical mass point. Certainly doesn't have to be 100% of the participants, but we're just not ready to do that. The second thing that's come up on data was, and I just want to do this as a reminder, is that while we issued the data specifications and there's a lot of different ways places you can enter data for: inpatient, outpatient, ED, prescription data, administration data. It is not a requirement of the collaborative that you do all of those or you can't send in data. So most of the people who had that question, we've already talked to one-to-one, but just in case, you've got everything you got, but you can't get prescription outpatient and you're holding off, you don't need to do that. If we understand that not everybody's systems are collecting the data in a way that you'd hope they would at this point. So I want to get that out there as well. The third thing, and then I'll sort of open it up for any questions. I'm not sure there are answers yet, but certainly we're recording a lot of questions. We've had several inquiries about adding opioids or compounded products that are not on the list. And should we add them to the list, or can we just go ahead and do those? And the answer to the question is you can add anything you would like to the list, to the this is our starting point list. And if you wish to include extra drugs in your file, you just need to let us know what those are. You're welcome to do that. We are welcome to include those in your report. Just understand it's possible that you might be the only hospital submitting that. There certainly wouldn't be any comparative data possible for those, but they would be a part of certain reports. For example, the prescriber report would certainly contain that information that's unique to just your facility. But we've been getting a lot of questions about shouldn't we add. I can tell you that Hallie and Liz here just came back from a national meeting last week in Iowa. It was a data meeting, and this topic came up. It is pretty clear that we are pretty darn close, if not the first, to attempt to collect this much data directly from the hospitals. And so there's a lot of questions about this. We're not duplicating a scientifically vetted process, and so these questions that your teams are coming up with are great questions. And frankly, we don't have answers to all of them. And we have talked to people, we've talked to the CDC, we've talked to SAMHSA, we've talked to other states that are doing opioid work. Everybody says mostly, yeah, that's a great question. It's just not there yet. So anyway, I just wanted to say, if your team has a particular drug, opioid, compound that is not on the list and want to include it, by all means do it. Just please let us know that you're adding it so that we can make sure that it's part of your formulary when we process the data. Does anybody have data questions they'd like to, at least at a minimum, for us to add to our list, if not answer for you?
This is Lillian. I've still got on my list a question our folks had about file specifications for denominator data. Has that been sent to them, or?
It has not, Lillian. That is a great, I'm glad you brought that up. It is on my list to get done. Honestly, that's on my shoulders, and I have not completed it. It just hadn't been on the top of the list because at this point, we have so many people that haven't turned in any data, but I know you've requested that, and we'll get it out shortly. It's a pretty straightforward one, but we just haven't gotten that far with it. And just so everybody's clear, what Lillian is asking for, in the file specifications, there are denominators that we're asking for, those are going to be able to be entered either into the portal, where you would open those and type those numbers in, or you'll be able to submit a file that just contains all your denominator information, and it is that specification for that file that Lillian is asking about, and it will be out to everybody, I would say, within the next 2 weeks.
Thanks, Jim. Appreciate it.
You're welcome. Any other questions on data, or for that matter, anything else? Everybody should have received their gap analysis from Hallie. Hope you found those in a useful format. If there was anything that was missing from it that you would like to see, we are open to that. Okay, hearing nothing, Hallie, I'll just turn it back to you for any final thoughts.
Thanks. Well, I just want to say thank you to everybody that participated on the call out, the folks that shared what was going on in their hospitals and in their communities. So I really appreciate that. And I don't have anything else, but we'll let you know where we end up putting the recording to be able to share that with you. And so we'll follow up with that. And I think that's all. I appreciate your time today. Thank you.
Thanks, everyone.
Thank you.